Um, so hi, everyone. Thank you so much for joining our fire safety community practice meeting. It's really, really lovely to be back together with you again. And we already have 17 people calling in. We're supposed to hopefully have a few more dozen. So thanks for taking the time out of your day. As Jenny said, we're going to get right started because we only have an hour with lots of interesting discussion to be had. Today's topic is burn prevention, acute care, and rehabilitation, learning across contexts. And we have a very esteemed panel that we'll be hearing from on these topics. Before getting into the agenda, I just want to remind you all of our shared ethos and how we hold this space in the community of practice. Please keep your microphone muted when not speaking, and we love to see people's faces. It is difficult to be remote and not able to have these sessions in person. So please, whenever you're comfortable, to just turn on your camera and say hello and give a smile. We hugely appreciate it. Please, for the speakers, the panelists, as well as in the Q&A discussion, make sure that you're being mindful of time. We ask that you don't take screenshots or record the session. This is something that we do as Kindling. We then actually get expressive permission from each speaker after the meeting on purpose, just so that they have full informed consent on what the conversation is. And so we ask that any AI note taker is not welcome here. I think Jenny can be monitoring those. And otherwise, we will also circulate with permission recording as well as meeting minutes. So don't worry, there will be a chance to learn from these sessions beyond the session itself. Please make sure you credit people with their ideas or words. And of course, we just want to make sure that we're all here to learn. So make sure that we're participating with curiosity, humility, as well as respect. We're very lucky to have people from all different parts of the world and different backgrounds, and that's what makes this space so wonderful. We want to encourage you to use the chat. Certainly initially, just to introduce yourselves. I think Jenny might have just dropped a note in saying, please say hello, let us know who you are in the chat, and then feel free throughout to share questions, reflections, or resources. And really, this is like a co-created learning space. So just excited for us to learn. I'm certainly myself looking forward to learning. And ultimately, the work that we're doing here is about making fire safety accessible to everyone. So Kindling will be looking at how the learning from this can go beyond the session alone. Again, the meeting is recorded by Kindling, so just to let you know that. Okay, we are going to jump in pretty quickly to the panel discussion. I only have a few points I want to talk about beforehand, really just kind of updates on the community of practice. And then we're going to do a quick introduction to the theme, and panelists, they're actually going to jump in themselves and really introduce you to the topic. And finally, we'll finish with Q&A discussion. What we found in these communities of practice is by about the hour mark, we tend to get to the end of the panel discussion, and sometimes people decide they want to stay longer for the Q&A. We don't send that out in the invite. It's certainly no pressure. Leave whenever you need to. But we found in the past that people actually want to stay on much longer, and we're very happy to continue the conversation. So that's just a kind of open invitation. Don't feel the need if you have a question to jump off. If you want to stick around and the person you want to talk to can too, then this is a great space for you to have almost like a tea coffee chat. Then I also want to give a bit of a trigger warning. I will remind this again later. Only 2 of our panelists have slides, and I've noted that at least one of the slide decks does have several images that might be difficult to look at for people who aren't familiar with kind of looking at medical journals or kind of working in the medical field. We're actually looking at images of people's bodies that are burned. This is obviously for educational purposes, and the speaker will walk us through why it's important for us to see these images. And also in general, the topic of fire in overall, as well as burns more specifically, can be quite difficult to kind of to listen to sometimes. So just pay attention to how you're feeling. If you need to step out and take a break, please do that. If after the meeting you want to talk to any of us about how you feel, we're always here and always happy to have another call as well. So the community of practice launched over a year ago now. We've explored several themes, which are on the top right hand of the screen, and there's many other
Sorry, I can't hear. Hello?
Yeah, Danielle, we can't seem to hear you.
We can't hear you.
I think Danielle's connection has frozen a little bit.
Yes.
Yeah,
I'm
I
sure
think
she'll be back.
Let's just give it a moment and she'll reconnect. It's actually for those of us who are on the call and based in South Africa, as possibly in other parts of the world, we have ongoing connectivity challenges of various sorts. So we do the best that we can, and we acknowledge that this is one of many kind of infrastructural and other types of challenges in doing the work. So thank you all for your patience. Yeah, I think it's actually a good moment as we're waiting for Danielle to come back in. Oh, Danielle, I see you moving. Are you with us?
I'm with you, but feel free to finish your thought, please.
I was just going to say it's a good chance I see more introductions coming into the chat. So it's a great moment to continue getting to know each other in that way. But welcome back, Danielle, back to you. I could see your eyes blinking, so I was like, yes, there's movement.
So sorry, I've hotspotted to my phone now. Hopefully it's okay. I realized I actually never introduced myself. I'm Danielle. I'm the founder and executive director of Kindling, and I'm sitting in Cape Town, South Africa, where normally I have very good internet, but for some reason it's not holding up right now. But hopefully we're okay now. As I was saying, there's many ideas for future topics and themes to explore. Several of them are already in the works with us trying to design sessions around them. And certainly we'd love to hear from you on what you're most interested in. And just a reminder, the Fire Safety COP is now part of the Global Shelter Cluster Technical COP. This is the link to go to the fire safety page. There's a few different resources there, and we do try to maintain that and upload as the sessions continue. So that's it as far as kind of the admin side of things. And then we're going to jump into a quick Mentimeter survey together. Please let me know if this is working for you all. I'm just going to switch presentation mode so that I can actually share the Mentimeter. Jenny, please let me know if this is coming through.
Yep, it's looking good. We see the map on the screen.
Perfect. Thank you. So we'd love to know where you're dialing in from. So you can just drop, I think it just lets you put a pin onto the map. So please drop a pin and we'll just see it live pop up. We have 24 people, so hopefully we get 24 pins on the map. We got someone in the UK. Is that you, Christy? Maybe you're quick. Not that quick. I think we have someone in Kenya. Looks like maybe Nigeria, Bermuda, potentially. I didn't know we had people dialing in from Bermuda. That's quite interesting.
Sorry, Danielle, that was supposed to be Boston, but I missed.
Oh, hi, Robert.
Hi.
Bermuda sounds lovely, though. So, I mean, I'm in the western part of the US. Great. And when we do give the meeting minutes, we like to give these maps just so we can see what regions are represented. Cheryl, I don't think we see you in India yet. Hopefully we'll get your dot on there. Thanks. Wonderful.
Trying to get it there.
Thank you. I'll give it one more minute just so that everyone can get on to Menti. There's a few more slides we're going to do together.
No, I'm having some trouble getting there. Okay, I got you. Sure. Got you.
So we have several people in different parts of Africa and Europe. Great. I think we have 14 people on. So I'm going to go to the next one, but you can kind of work your way through the different questions. So we'll still collect data.
So please wait for, okay.
So which sectors do you work in? Do you work in the humanitarian sector, in urban development, fire safety, or something else? If you work in a couple, it's okay. I would consider myself working in all of these personally. So we've got certainly some representation from humanitarian sector, fire safety. Great. And with this COP, we're always looking to try to get a distribution across these sectors. While the COP is hosted in the humanitarian sector, we're really trying to bring in non-traditional actors, especially from the fire safety research and practitioner worlds into this space. So it's really good to see that diversity. Okay, you just saw a slide where I had asked what topics or shown what topics we're thinking of for the next sessions. This is an opportunity for you to add some more here. If you also think about this more throughout the meeting, feel free to put this into the chats. I might come back to this later on as well. I really want to jump into the next question as a bit of a primer for this session. So what should you put on a burn immediately after it happens? Let's just give everyone a few minutes. And then our first speaker, Chrissy, I think I'm setting you up, Chrissy, to maybe answer this question yourself as well. We're saying water, depends on the severity. Running water. Lots of water. I'll see about half the group has answered. Plastic wrap, okay. What about toothpaste or butter? Not ice water, okay. Not toothpaste or butter. Great. Aloe vera, interesting. I was setting you up. Toothpaste and butter are bad to put on burns. Okay, and then final question. We'll go back again at the end to just check if there's any more answers. But who is responsible for burn prevention, acute care, and rehabilitation in humanitarian settings? Are there particular clusters? Are there particular agencies? Does it depend on the context? Would love to see what people perceive to be who is responsible in the sector. I don't know if people aren't to this question yet, or they're just a little bit shy. Concerned stakeholders, okay. All right, so I'm gonna jump out of here, but I encourage you to please keep going in and adding your thoughts. Again, this is something that we do and extract into our notes and everything afterwards. But we're gonna go into the panel discussion just so that we can really take advantage of the time we have together. So first, I want to introduce our panelists. These are our 4 wonderful panelists today. We have Christina Stiles, who's sitting in the UK, Janetri Gavinsmi, who is in South Africa, Cheryl Rebello, and Vijay Joseph, who are our 4 panelists. I'll give a proper introduction to each of them in turn. First, I want to introduce Chrissy. Chrissy Stiles is a nurse of 22 years with a passion for pre-hospital burn care, burn education, and first aid, exploring all opportunities to advance prevention of burn injuries and awareness of the life-changing impact of early interventions on burn survivors' quality of life outcomes. Chrissy is a proud ambassador of Children's Burn Trust, is the co-author of Saving Lives Is Not Enough, which is a wonderful children's book, and the author of Family Ops. Oh, sorry, that's not a children's book. The last one is a children's book. And the author of the Family Oops and Burns First Aid children's book, which is really wonderful. So Chrissy, I'll hand over to you. Thank you.
Thank you very much, Danielle, for that introduction. I don't have slides, so I will just generally talk at all of you, and hopefully that's okay. So as Danielle described, my passion is in burns first aid and prevention of burns. And generally, I believe that all burns are preventable. WHO, so World Health Organization, tells us that about 180,000 people die of burn injuries globally. And that's a hell of amount of people. When I tried to do the math, and maybe some of you are more clever than me as to how many that is, but I think it worked out to something like 500 people a day that perish from burn injuries. And that's just a ridiculous number for something that is so easily preventable. Overall, about 11 million people have burn injuries and survive the consequences of those injuries. And that can be lifelong and life-changing, not only from a scarring point of view, from a visible difference point of view, but societal exclusion, isolation, challenges with strength, with function, and being able to have quality of life. That's 11 million people every year that will struggle following sustaining a burn injury. Our national and global data tells us that a majority of burn injuries are actually sustained either at home or at work, but it predominantly happens in the home setting. And half of all of those numbers that I've just quoted are actually burn injuries in children. And predominantly, this is children under 5 years old. The type of injury that is sustained is usually not something the child would generally interact with. So injuries from hot drinks, from cooking, children wouldn't make hot drinks necessarily, they wouldn't necessarily be cooking, but yet that is how under fives mainly get injured. So when we think about our safest places, our homes usually, that is where we get injured the most, usually in the bathroom or the kitchen setting, sometimes in the living spaces if it's overcrowded, a lot of people around, food is being served, hot drinks around. That is when the danger lurks. And in the UK and in the Western communities, a lot of this tends to be from hot drinks. So we've got a National Burn Awareness Day coming up on 15th of October, where we're going to be yet again for yet another year telling parents about the dangers of hot drinks near young children. So we all wander around with our hot drinks, teas and coffees, and a young child nearby is inquisitive, either grabs it, pours it over themselves, or pulls it off the surface of the kitchen table. These injuries happen in a moment's flash, and they are absolutely dramatic. They're devastating. They're incredibly painful. I'm sure most of us in the audience have had some experience with a burn, even if it is just from an ironing or a cooking accident. And we know just how painful and horrible it is to experience a burn injury. Now, for the youngsters, for the little children, a small drink that I might be holding in my hand goes a very long way. That's a lot of their body that would get covered with that hot liquid. And it's because children have much thinner skin, their burn ends up being much deeper. Majority of parents don't know what to do as first aid. They don't have that prior knowledge as to appropriate care for burn. And actually, scarily, a lot of our research also suggests that healthcare professionals also seem to lack this knowledge too. So the bit that once the accident has happened, the part that can actually help reverse the damage or make the damage less severe, we don't have prior knowledge of that. So parents either don't deliver first aid or apply inappropriate products, or healthcare professionals delay applying first aid or think that the time has already passed. So we started, I'm going to get you to write in the chat very quickly, so let's get you interacting a little bit more. We already established that a lot of you think that water is the right thing. How long should you be pouring water onto the burn? So put in the chat just what you think. How long do you think I should be pouring water onto a burn if I've myself or my child has had a burn injury? Are we thinking minutes? Are we thinking hours? Are we thinking seconds? Just type in. Excellent. So it's starting to come through now. You're starting to interact. A few more responses. There's 5 minutes. There's 20 minutes of running water. 10 minutes, 20. Again, any others? 10 to 20 minutes. So I already see the difference of opinion just across our own audience. So if we can't agree, how can we expect the parents to know what's the right thing is to do? The answer is, it is at least 20 minutes of cool running water. That is what our evidence base of 2 decades now shows, that the way to reverse the depth and the size of the burn injury is to pour 20 minutes, ideally running water, onto the burn as soon as possible, or there is a time scale. So we've agreed that it's 20 minutes of cooling that's required to reverse the depth and the size of the burn. It means that the burn will be less deep and may not need to go to hospital. The child or the patient might not need to have an operation. It means that they're less likely to have infections. It also means that they're less likely to have an operation and less likely to heal with a scar that will last with them for the rest of their life. So that is the benefit of cool water, applying that cool running water for 20 minutes. Obviously, if the burn continues to hurt and you still want to stay underwater for longer, that's fine. But in terms of skin recovery, 20 minutes at least is what it takes to reverse that damage. Now, there is a time scale, like I said, as to when this first aid is effective. So in the chat, can you please put down when you think the effectiveness of first aid will stop? So if it's happened an hour ago, 3 hours ago, 6 hours ago, is there a time frame when first aid is effective? So if you think it's only 20 minutes, it's effective. If it's much longer than that, can you put in the chat efficacy time frame for burns first aid? Okay, 24 hours. Any others? 1 hour. Excellent. Keep coming in. 12 hours. Excellent. So if it happened 12 hours ago or 1 hour ago, 20 minutes is still effective. 2 to 4 hours. The answer is 3 hours. The burn first aid, the 20-minute, is effective within the first 3 hours of the burn injury. So if it happened in the last 3 hours, you can still do 20 minutes and you can still reverse the damage of the burn injury. If it happened after 3 hours, it will still feel nice to the person affected that you're cooling the burn, but the skin damage is already done. So if you are caring for somebody, are with somebody who sustained a burn injury, within that 3 hour window, do the cooling, do the 20 minutes cooling. And it is for any depth and severity of the burn, absolutely, because the burn itself is a 3-dimensional being. What you see on the surface of the skin might seem deep, but the stuff underneath that burn injury will still be inflamed, and still the process is degrading the tissues, still making them die off unless you apply the cooling. So that really works. If it's a very big burn that covers quite a large body surface area, you don't need to cool the whole person all at once, because you would get them very, very cold and hypothermic. So idea is that you cool a part of the body at a time for 20 minutes. So you could do one arm for 20 minutes, another arm for 20 minutes, but keep the rest of the person warm. And finally, how cold, how cool does the temperature of the water need to be? So put down in the chat, how cool do you think it needs to be? Is it cold, not very cold, lukewarm, super warm? Just in terms of coolness, how cool does this running water need to be? 20 degrees C, room temperature. Any others? That's very good. Keep them coming in. So room temperature, absolutely. I like the way that you're thinking. Not ice water, not cold. Absolutely correct. You're absolutely right there. If we apply something that's super cold, firstly, the person will never last 20 minutes. It is painful to have really, really cold stuff applied to you for that length of time. And you could cause hypothermia, which can make them even sicker. It also could potentially cause a frostbite injury if you're applying direct coldness, so something like ice. If you're applying it direct onto the burn wound, it makes it much worse. So we say room temperature 15 degrees and above, anything that's body temperature warm, room temperature warm, that's tolerable for 20 minutes is perfect. So hopefully now you've gathered that what we need to do for a burn, should it happen, within the first 3 hours of the burn injury is 20 minutes of cooling with cool running water, and the water doesn't need to be icy cold. It needs to be room temperature warm. Perfect. If you walk away with one thing, that is fantastic message for you to take away. So overall, I just want to conclude that the burn injuries are preventable, but first aid knowledge doesn't exist as standard across our communities. If we are confused and if we don't know quite what to do, then obviously the general public and our communities don't have that knowledge, and healthcare professionals also lack that knowledge. So we need to gather together to try and work out how we can plant that seed that actually reversing the burn size and depth is very, very simple. To avoid admission to hospital, to avoid surgery, to avoid scarring for life is actually quite a simple fix. If we do that, potentially we have really good quality of life for the burn survivor. So hopefully that's everything that you need from me, and I will deal with the questions in the chat further on, but I'll pass on to the next speaker. Thank you very much.
Thank you so much, Christy. Really, really helpful. And this is information and knowledge you can take home right away. So please go home, tell your families, tell your friends. This isn't just about preparing for humanitarian crises and responding. This is also about our own lives as well. So thank you, Christy. Okay, so next up, we're going to have Cheryl Rebello give us a short talk. Cheryl is the CEO of Beyond Carleton, and she's inspired by the mission of saving lives. She has played a core role in the institution building work of organizations devoted to social purpose. In particular, she has worked to develop programs to shape a prepared citizenry through emergency and neighborhood safety training. She has led efforts in urban governance, civil defense engagement, and rural development. Cheryl was actively involved in projects to promote burn care and life safety in Bangalore. She also served as a trustee on the board of the South Asian Symphony Foundation, an organization that seeks to promote peace through cultural diplomacy and music. So Cheryl, so lovely to have you with us today. Thank you for being here. I'm gonna be your slide girl, if that's okay. So please just let me know when you'd like me to move slides. Is it coming through for you okay? Cheryl, can you hear me?
Sorry. Yeah. Thank you so much, Daniel. I can't see the slide as yet. I can see the panelist slide up. Yeah.
There we go.
Thank you.
Just let me know when you want the next slide. Thank you.
Sure. Thank you so much. I've called this theme the Burns Reality and Navigating Invisible Spaces, a Beyond Carleton effort. Yes, please, to the next slide. Quickly taking you through the organization that I'm with and the project that we worked closely on, a burn care, burn prevention, burn care effort called Fire Watch 101, the approaches that we took in the course of this, and then really what is this invisible reality and the context for change. Yes, please. Yeah, just to say that the organization that I'm with, Beyond Carleton, a few words about it, primarily focused on fire safety prevention and also towards looking at improving conditions in communities, in vulnerable spaces, hospitals, residential areas. And our mission is essentially to create more fire safe cities. And it was started by Uday Vijayan, who is the founder of Beyond Carleton, who lost his only son in this fire and then dedicated the purpose from disaster to saving lives. And that's Beyond Carleton. Essentially working around advocacy, because I think just like burn care, fire safety also needs people to think and to create importance for the issues around fire safety. So advocacy, raising accountability is an important part, and of course awareness, which is also one of the more challenging areas to grow and to broad base. Our tryst with burn care has been a long one. We are long-standing advocates for increasing access to burn care, also because of the mortality and the life safety issues which are linked to burn care. We've been doing this for a while. And we want to ensure that uh, as we go along our primary mission of fire safety, that we're also continuously looking at how we improve the burn care environment uh, currently in our state and then in the country. Yes, please. Yeah, Daniel, please change the slide. Project Firewatch 101 is the burn prevention, care, and rehabilitation effort of Beyond Carlton. And we did this along with one of the fairly large and the only hospital other than the St. John's who is looking at specialized care for burn care in the entire state of Karnataka. So it's a very telling statement that there are only 2 hospitals, and this was supported by a company, a CSR, a corporate social responsibility effort. The areas that we supported were immediate care, burn prevention, and also rehabilitation. These were the cornerstones of this project. The areas of impact were really on the number of patients we took on and how we were able to move from direct medical support to beyond that to rehabilitation and to continuous prevention efforts. Yes, please. Just give you some data over there to the number of people that we supported during this project. We were able to gain insights because for a fire safety organization, it was really new area that we were traversing. And we were able to gain insights into some opaque areas and understood aspects of access to burn care, which is the ease of obtaining professional support and burn care. Capacity, is there infrastructure specialized for recovery, skin banks, surgical equipments. We found that there was constant need for that, and physiotherapy centers and skills, like always the number of people who are attached to hospitals was always seemed to be overwhelmed with the number of people at these centers. Yes, please. Yeah, the approaches that we took quite naturally were from in our discussions with with Victoria Hospital was firstly the immediate care, because burns are such that there's always an emergency to get the medication given immediately. And we felt that there needed to be continuous preventive activity because, like the big line is, prevention is better than cure. Like Dr. Smita says, that's the line made for burns. And then the long term, which was about the tough road of rehabilitation. Yes, please. It changes that. Some data here, I mean, some of the areas that we found difficulty was to get data, to be able to have the hospitals record the data. And we needed to do it for the purposes of the project, for the purposes of reporting. And so you can see we were able to create some kind of data recording, as you can see, names, because of confidentiality issues, because of legal issues. We were always not able to see the entire picture. And we were able to then look at, can we get percentage of burns? Yes. Can we get just the age group? Can we get the age group? Can we get causes of burns? So, very gradually nudging the system, nudging the hospital to be able to provide this kind of data. And obviously underlining for us, what can we build on? If we have data, we could build on, but if we don't, it is always difficult. Widening the professionals network. I think while we were dealing with doctors from the hospital, we were constantly looking at who are the other influencers who can change some of the patterns inside this hospital. So how can we get professionals to learn to contribute to each other? And also looking at life skills for life safety prevention, which was, we started looking at it to kind of promote it, to say these are life skills for life safety. So this is what came up as part of our prevention effort, and also looking at taking very incremental steps, because the hospital that we work with, and we know it's true of others as well, they were always overwhelmed by burn care. So there was very little time for prevention. Yeah, please change the slide. The more I reflect on it, and I understand that prevention is presence. It's a presence and a readiness to accept that burns is an important issue, and we need to set aside some attention apart from apart from immediate care. We also need to look at some signposts to say that we believe that prevention is important. And also things like life safety, allied service groups, skills and outreach. Are we able to visibly see people taking prevention seriously? Okay. Yes, please change the slide. Some of our efforts towards prevention was looking at groups which were vulnerable, which were at risk, like construction workers. We did some work with school children, but through all of this, there is a common thread of being able to broad base the groups. So it was the management, it was it was medical professionals from even within the construction workers. We had a kind of a mixed group, and also the management was involved. So in a way, we expanded the base of what we were speaking about burn prevention. And the same thing went for students. We were talking to the management of the school, we were talking to teachers, and these are kind of the efforts that we put into, again, under the banner of life skills for life safety. So saying that it's important. Otherwise, I mean, like fire, why it won't happen to me, and it burns, well, you know, how common is that? So people tend to so pushing this along to say these are skills that can last you a long you know, for your lifetime. Yes, please change the slide. This was an interesting, we did this for linemen and women from the Bangalore electricity supply company. Again, another workshop. An interesting problem statement where the body, the utility told us that linemen and women were not concerned too much about their own life safety. They were not concerned. So that was the problem statement where we began from. So it was a lot of attitudinal change to say that if you are improving conditions for people, how along the patterns of what you're doing in your work, how can you see yourself as important and introduce life safety within what you're doing? So it was a very interesting interaction, and I can speak more about it if there are questions as to what we did. We create a kind of mind map where the linemen and women were able to reflect on the importance of life safety. Yeah, the utility was concerned about the dangers that they faced, and the accidents levels were increasing. But that was not because the conditions were not conducive, but because the practitioner, I mean, the linemen and women themselves did not see life safety as an important part of their execution. Yeah, please change the slide. Please change the slide. Sorry, please change the slide. I can't. Daniel, can you hear me? Can you hear me?
Yes, I can hear you. I'm sorry, I was having more computer issues.
Okay.
Do you want me to, can you see my screen
No,
still,
this is
Cheryl?
fine. This is fine. Yes, I can see your screen.
Okay,
This is part
great.
of the continuing prevention work. We also did this kind of a workshop in interactive engagement with the professionals and the doctors at St. John's. Dr. Vijay is there in the picture, and we were able to learn about another perspective from the professionals. So we continue to expand our area of influence across various groups, including the professionals. Yes, please change the slide. Rehabilitation is a longer journey, and we did one such case with the a young man who lost his limbs in a fire thing, and we were able to create and understand what are the journey, what are the steps, and there are 2-3 areas which is more about counseling, psychological support, apart from cost, and the reskilling, so and the reintegration, a long journey, but we understood some key aspects of that as part of our approaches to burn care. Yeah, please change the slide. The invisible reality really begins, number one, with data, and I'll go quite quickly with this. Obviously, very little gets reported and very little gets recorded. The causes of burns, if I can just read this quotation, we see domestic issues, suicidal cases, interpersonal conflicts, family disputes, but the case history can change. We can only document the patient, what the patient tells us. For example, if the patient really initially says someone poured oil and then on them on fire, and then the next they change that, it's their story. We are not investigators. So in a sense, there is still opacity about what really are the causes, what really are we trying to prevent. In a sense, we know that, but it doesn't get come up to the surface. Professionals who promote, who take it upon themselves, and I must say that with Victoria Hospital, the doctors and Dr. Smita Segu, who is played a very key role anchoring burn care who plays a very key role, they and the doctor, her doctor colleagues, got off the main line and really took time to get into the preventive aspects, which was tremendously helpful for us in this journey. There are accessibility challenges. As I said, for the state, we have 2 key hospitals, and so down the line, right closer into the community, there is fading. There is not much or not at all, burn centers to deal with. So we have that issue. There is issues on psychological support, and community education is still a very opaque area. Absence of infrastructure, as I said already, and information resources, media engagement, all of these areas are pretty opaque. Yes, please change the slide. The context for change is how can we promote, and I think we are in India trying to do this, and we all need to gear up towards creating a burns registry. Build examples. I think that's what we found quite useful in the Project Firewatch 101 that we did, that when you see an example of what's working, it's easy to replicate. A detailed good practices, build an alliance of practitioners, specialists, nutritionists, and all of the allied service groups that need to be part of the burn care and prevention space. Build capacity through lessons learned. I think that documentation still needs to happen to help us. Replicating from learning from good examples, I think is clearly something that we see as what works. Small steps, but we keep replicating. Advocacy for prevention and the presence of information in decentralized spaces right up to the community level. I think that's what we really need. And I think we need it at various places also, like schools, colleges need to put it out there into their, whether they have safety clubs or residential areas, emergency training. All of these need to also include burn care. And decentralized centers of burn care, which, as I said, it increases the time taken for a person to have burn attended to. So I think these are the core areas that we have picked up, and I know there's a lot more. So I'll stop with that, and I hope I'm okay on time. Maybe I have.
Thank you so much.
Yeah.
Thank you so much, Cheryl. And please add questions, comments into the chat. We are going to swiftly move to our next speaker. We have just 15 minutes left, so I'm just going to ask the speakers to please be conscious of time. Next up, we have Dr. Janetri Gavinsmi, and we're really, really pleased to have her here as a South African physician with extensive experience in rural medicine, pediatrics, anesthetics, surgery, palliative care, and burns care. She was instrumental in establishing and leading burn services in KwaZulu-Natal, including setting up the first dedicated unit at Ngwelezeni Hospital and later directing the Gray's Edendale Hospital Burns Program. Her work focused on clinical leadership, multidisciplinary training, and innovative outreach, such as the Burn Doctor Hotline, to improve care in resource-limited settings. And since 2018, she's run a private general practice while continuing to draw on her background in burns and trauma care. Thank you so much for being here, Doctor. Over to you.
Okay, thanks. Thank you, Danielle. It was lovely listening to Cheryl and Chrissy. So I recognize these problems that you're all speaking about. So my experience with burns in this particular part of South Africa, KZN, I think is in many ways typical of what a lot of people are experiencing in many parts of the world, where, first of all, there's limited resources on many fronts, but the part that was of interest to us was burn-trained professionals, burn doctors, specialists, surgeons. So the end of the line, you know, when somebody gets burned and they come into the healthcare system and they actually need expert support, first of all, it's very difficult to get that process moving quickly enough, and secondly, to get space in the very few beds that are usually available if they really need a high-level burn support facility. So what we found is that there were many breaks in the communication chain, and coordinating things was very, very difficult. So what we attempted to do at that point was set up something to link at least some of the components. And we did that by creating a hotline, a telephone hotline, specifically aimed to for the doctors primarily and the nurses in primary health care. And these would be doctors that are based particularly at the rural and regional hospitals. So these are non-specialized hospitals or clinics or community centers where people would usually first present, you know, for them to get to the regional and tertiary and highly specialized units, they need to be referred from the primary levels. And that referral process just delays a lot of things, particularly when people on the front line don't really, are not experienced, and they miss the golden opportunities that are showing up when a burn patient comes in. So one of the things that was really important that we had to consider is that a burn injury, if a healthcare professional is receiving a patient who's just had a burn injury, whether it's acute or chronic, but if we're speaking about an acute burn, it's very frightening. It is a very frightening thing to see, even as an experienced doctor, because these are not things you see often. So it usually shakes one up. And doctors and nurses that are usually very, very competent and clear-minded often get thrown when faced with these injuries. And particularly, as Chrissy said, a lot of these are children and young children, under 7, under 5. So there is a massive psychological impact, not just on the patient and the families, but on the healthcare professionals. And at that first stage when patients come in, there's very little support for them. So we attempted to set up this hotline with the very simple guideline that should anybody receive a burn injured patient, they immediately just call the hotline. And that would put them into contact with our very tiny team of relatively experienced doctors with burns at the at the referral center in KwaZulu-Natal. And we would then help them assess. We could talk through what they were seeing. They would send us photographs so we could help them actually figure out the percentage burn and then take them through the immediate treatment protocols or resuscitation protocols right then and there. The other thing that we found is, like you rightly said, Chrissy, the first aid awareness and immediate measures. A lot of doctors do need to be educated on that. So what would normally happen is patients would turn up at, let's say, a rural hospital, or even some of the bigger hospitals, and they don't get recognized as urgent cases. It's just burn. So, the old mindset is the burns you just leave it and wait and see what happens. Either the patient months later is going to survive somehow or not. So things have changed quite a lot in the last many years, but the mindset still needs some shifting. So to understand that a burn injured patient, especially when they're presenting acutely, so that's in the first hour to 4 hours, actually should be treated as an emergency, if only to continue with that first aid. So those first 4 hours, the first aid in the hospital setting is often something that's missed. And that was a huge part of the education, ongoing education that was woven into this system that we attempted to put into place. So the first aid. And then the other thing that was a huge missing piece was actually accurate diagnosis, accurate assessment of what somebody was dealing with. So how to assess a burn, because what we also found is that patients were not only getting delayed or mismanaged at the front line, but also if they were referred, the diagnosis was often so far from what was really going on. For example, somebody may assess a total body surface area of 5%, and it turns out they have, 15% injury, or vice versa. So you land up either not referring patients, or patients that should be referred get missed. So that very first assessment of actually what are we dealing with? Is this a patient that needs referral? Is it a high risk injury? Do we have special areas involved? And how to do that? So to really bring all the pieces together into one system that's in easy communication with, the different parts are in easy communication with each other, and that there's facilitation of the bridges that are needed, transfer, ambulance services, what happens while we're waiting, making sure there's space at the referral center when the patient gets in. All of these things were very, very important. So, the other thing, like you mentioned, Cheryl, the data collection, just record keeping on burns is terrible, not just because hospital records are usually bad, but also because the doctors and nurses don't know how to record their findings. So that is also a huge part of the education. What are you making note of? What are the important factors? And it's surprising how many things get missed when somebody is first admitted and assessed that you just cannot find on the records when going back to look for these details, which then should form very important statistics that we can do something with in the long term. So building a system so that essentially there was a tick list and a standardized form where we could just run through it. Well, these are the things: age, cause of the burn, time, actual time of burn, actual time of presentation, all of the various details, which would seem obvious in a cool and collected environment, but in the heat of the moment, when everything is happening, and here is a patient that is terribly frightening for the most part, and there are other things that you're dealing with in hospital settings. Having things in place to support the practitioners at the front line, I found was a really, really important thing. So it is a piece of the big chain, prevention on the ground level. But once the injury happens, what happens next? Yeah. So I think I will just speak to that bit for now and leave it at there, and we can come back to other things if need be later. Yeah. Thanks.
Thank you so much. Really, really appreciate your reflections and hearing about how you've actually created systems to connect doctors and patients in all these unique ways. So really appreciate you being here. We're going to move on to our last speaker, and I want to apologize a bit in advance to everyone here to say a bit of maybe poor playing on our part. I think this needs to be a 90-minute session, and we really, really hope that everyone's able to stick on, because I didn't want to cut across anyone speaking. There's just too many important points being shared today. For the future sessions, we will be sure to make sure they're 90-minute sessions. So with that, I am going to introduce our last speaker, Dr. Vijay Joseph. Really grateful for you to be here. He is a professor of plastic and reconstructive surgery at St. John's Michael College Hospital in Bangalore, India, where he has served as faculty since 1992. He completed his MBBS at St. John's Medical College, followed by an MS in General Surgery at Bangalore Medical College, and then he got a degree in plastic and reconstructive surgery at PGIMER in Chandigarh. Beginning his surgical career at St. Martha's Hospital in Bangalore, Dr. Joseph has since dedicated more than 35 years to the management of acute burn injuries and post-burn deformities. His longstanding commitment has made him a leading figure in the field of burn care and reconstructive surgery in India, and we're so delighted to have you here, Doctor. I do know that you have some slides, so I'm going to share my screen. And please let me know when you'd like to change the slides, and I can do that. As I mentioned earlier in the call, this last presentation does have some imagery, and so I will just say trigger warning in particular for this talk. But over to you, Doctor. Thank you.
Thank you. I hope I'm audible. Do you hear me?
Yes, we hear
Okay.
you well. Thank you.
So I think I'm having some issues with the with my picture with the video, but we can go ahead with the. You can move on the slides. So I'm just going to talk a little bit about the management, rehabilitation, and prevention. And I would like to thank the previous speakers. It was very nice and very informative listening to all of you as well. Could you move on, please? So most of the burns that we see are due to flames, and the pediatric burns, which probably is about 20 to 30% of our practice, is from hot liquids. We also see some very serious electrical burns. Chemical burns, fortunately, have been few and far between. The next, please. Could you move on, Daniel? The next one, please.
I think maybe we lost connection, Dr. Vijay.
Oh, okay.
Cheryl here. I think maybe
okay,
because
Sure.
I think
So
it's
shall I just keep talking while we are going on so that we don't lose out in time? I can do that, and then we'll catch up on the slides when they come to it.
Oh, okay.
So we've already covered the the thing about first aid and water, and I think Christina was fabulous with telling us that you could do it up to 3 hours, and that we could run them for 20 minutes. One of the challenges in our Indian situation is that we have a lot of stagnant water, which can be a cause for infection. So running water is great, but even if you don't have that, it's good to have them cooled with water. And we found that whoever uses water after the burns, the depth of burn has always been significantly less than the ones who didn't. So we kind of need to differentiate when they come into, the next please. We need to differentiate minor from major burns. We need to decide what can be managed as an outpatient or what might require admissions and what may need to be referred to a major burn center. So this is where the triage really would, a simple triage system. Next, please. So I would say that anything less than 10% we could manage as an outpatient. When it's between 10 and 20% of burns, you probably need to have them supervised much more. Certainly in a pediatric patient, you would have them admitted, and I'll explain why. And any burn over 20% of the body surface area, I think should need a specialized center unless the primary health center is trained to look after burns. The next, please. So why should a burn of over 10 in a child or over 20 in an adult, why should they be hospitalized? And that's because they lose a lot of fluids from the blood spaces. So that results in their blood pressures being very low, which can affect the kidneys, and they go into acute kidney failure. So in the past, before we understood this, there were many people who would die of acute kidney failure after a major burn. And the other problem is that after a major burn, your intestines and stomach could be sluggish. So you may not be able to feed them or give them sufficient fluids by mouth. You might need them to be on intravenous fluids until their intestines start working. So these are the two main reasons I would think why major burns need to come in. And then, of course, your skin is a barrier from external infections, and that is lost when you have major burns. The next slide, please. So it's important to decide whether it's a superficial burn or a deep burn, because if it's a superficial burn, most often they'll heal on their own. But if it's a deep one, they could get scarred, and they could also, the chances of losing them or mortality is very high. Next, please. We could move on, Dania. Yeah. So just to say that if you have a deep burn, they could get extremely scarred. Next, please. Which would need to be excised and then grafted subsequently. Next, please. We could move on, Daniel. Yeah. So just, this is a cross section through the skin, which shows the superficial epidermis, which are superficial burns going into the upper part of the dermis. And when it goes to the entire thickness of the skin, then you get deep burns. So how do you differentiate a superficial burn from a deep burn? I believe the best way to do it is from looking at it. Can you move on, please? We use something called the rule of 9, when we talk about percentage of burns. So we've kind of divided the body into 11 segments of 9, where the upper limb is 9, each lower limb is 18%, the anterior trunk is 18%, the posterior trunk is 18%. Another simple rule that we use is that the palm with the fingers open is 1% of that person's body surface area. The next one, please. So superficial burns could be first or second degree, and the first degree burns in our skins we find are slightly coppery brown. But the moment they're second degree, they have blisters. When you remove the surface of the blister, you'd find that it's either pink or it's bright white. Could we have the next one? Next one, please. Forward. Yeah, so just to show the blisters, the next one. And the pink appearance in a superficial burn once the blister is removed. The next one, please. The deeper burns, they could look like parchment paper, or they could be leathery, they could be grayish, dull yellow in color. So we'll move on to the next one, please. This is a leathery burn just to show the parchment paper and what we call the marbling of the veins on the skin. The next, please. So that's a full thickness deep burn. And this is again a grayish yellow opaque skin of which is a deep dermal burn. The next one, please. So these are all deep burns, and it's extremely important to differentiate superficial from deep. So there are certain patients who need to be admitted, and children, like I said, with more than 10% or adults more than 15 to 20%. If you have inhalation burns, so you could have the respiratory system burnt, they need to be admitted. Any deep burns which are likely to give deformities, we would admit. Electrical burns, because you don't know what you're seeing, may be just the tip of the iceberg. And other disease conditions. The next, please. The next one, please. So if the burn is in a closed space, or if there have been chemical fumes, and if you see singeing of facial hair, you should suspect inhalation burns, and this can change the mortality significantly. The next, please. We could move on there. Yeah, just to show the hair, the facial burn, the hair which has been burnt. And if you look into it with a scopy, you would find that the oral passages and the respiratory passages could also be burnt. Next, please. So the main management is intravenous fluids. It's the superficial burns especially can be extremely painful, so analgesics. We try and start feeding early as soon as the intestines are functioning, and topical therapy is the other important thing. One of the things that has changed things for us a lot has been early excision and grafting of the deep burns. The next one, please. We could move on. So we use the dressing predominantly to act as a closed environment to protect it from the outside, but also to reduce pain and to absorb any discharge which might be there. The next one, please. So we would cleanse the area thoroughly. We prefer to remove the blisters. We could give them a shower. You need to be careful that the water does not cause any infections, and then use a non-adherent, absorbent, bulky dressing and some form of antiseptic cream. The next one. We could move on, Tanya. Yeah, just to show that under this, he has a non-absorbent area and then a bulky dressing, which would be dry on the outside so that nothing from the outside can penetrate and reach his wound. The next one, please. So we do early excision, and this is the instrument that we use to cut out the dead skin and come to healthy skin. The next one, please. You could move on, Daniel. I think we can. You can move to the next one. So in the past, we would have found it extremely difficult to save the life of someone like this. This is a deep dermal burn, which we were able to excise. And in the past, again, we would use relations skin as a temporary cover. And this was something that was done for him. So this is called a live allograft. Can you move on, please? You can see that we've kind of meshed it and stretched it out. Can you move on? On the right-hand side, what you're seeing is the same allograft, which is now beginning to separate after 2 to 3 weeks. And on the left-hand side, the same patient who's completely healed. Nowadays, in the skin banks, we get glycerol-preserved allograft, which is not live. It has its role, but live allograft is something that I would pitch for. The next one, please. So just a quick word on rehabilitation. It has to involve most often physical, a lot of emotional, sometimes educational, social is always involved, and most of our patients need a lot of financial support. We found when we had a supportive burn group going, or a burn support group, it worked really well for most of our patients. And if we go to the next one, this is a lady with fairly extensive burns who underwent early excision, who was in her intermediate or early late school. Then the support group put her through school, put her through a technical service, and she now looks after the outpatient department in our hospital. Move on. So she got a technical skill and she moved on. So she's kind of fully rehabilitated at this point and very confident, and trains everybody else who comes into her space. Thank you. I think that's the last for now.
Thank you so much, Dr.
few-
Vijay.
I just put a few points of what we see, which may be different from others. A lot of the children come to us with injuries because the parents have been the mother has been cooking on the floor, and they've been kind of accidentally knock into some of that or spill something over. The other thing that we see sometimes is that the mother's in a hurry, turns on the hot water of either the shower or in the bucket, and the child gets a scald. We've been seeing a lot of burns in the elderly. And during religious ceremonies, they use an oil lamp, which is most often on the floor. And this is something which is unique probably to our country. And we might need to look at ways in which we can prevent this, because the mortality is fairly high. The electrical wires, like Cheryl was saying, besides the fact that they tend to drop their guard, I think we don't give it sufficient attention, and ways in which we can prevent them either falling down or people touching them when they're going to work on the tension wires. And safety of our gas cylinders, again, is extremely important. Thank you.
Thank you so much, Dr. Vijay, and I'm very, very sorry for my technical struggles throughout your presentation. I was clicking as soon as you told me, but I think there was quite the delay. So very, very frustrating, I'm sure. But really, really appreciate you pushing through. With that, so we're going to open it up for questions and answers. As I mentioned before, the Menti is going to stay open. So even after the meeting, if you want to add your thoughts on the Menti, please feel free. Otherwise, I'm going to just open it up for discussion. If anyone wants to raise their hand, please feel free. Definitely encourage people who are in the audience to engage directly with the experts we have today. Otherwise, I will see if I'll maybe ask you, Jenny, if there are any questions we should be aware of. Feel free to pose them to the speakers if there's some coming from the chat since you've been monitoring.
Yeah,
I can
thank you so
see.
much.
Oh, sorry. Go ahead.
Yeah, I really appreciate. I think as I've been tracking with the chat, the speakers have been responding to the questions as we've gone along. So I haven't picked up any questions that haven't yet been answered. Just a lot of interest in resources and sharing it back into people's respective communities. Some questions about kind of alternative means and methods that can be used in different settings and contexts. But let me pause there because I think, yeah, if anyone has a question that they'd like to say out verbally, that's also much appreciated. Or if any of the other presenters on the panel would like to respond to each other, that's also very welcome.
Yeah, Chrissy, please go ahead.
I just wanted to say thank you to the panelists who followed my talk. It's really good to hear from different angles and different needs of what our patients might present with and the challenges. And whilst we're saying that there are resource poor environments that are usually most disadvantaged with the knowledge and access to care, in a similar vein, like Janeshri said, we are also lacking specialists who are trained in burn care. And I think that's a global problem, even in the Western community in the UK. The last couple of meetings, we noted that we have a really bad retention problem in the burn service, and we can't attract new people to come and work because it's a job for life. You have these patients for the rest of life. As you saw from Dr. Joseph's presentation, the scarring, the reconstructive surgeries, this all happens over many years. And in case of children, it happens decades later. The reconstructive operations continue on until they're adults. I'm really glad to hear from a lot of the speakers that there is peer support available, because if nothing else, actually it's parent support, parents of children with burns supporting other parents of children with burns, or burn survivors who have recovered or further down their journey are supporting the burn survivors who are still quite new into their condition. I think there's nothing quite like that support mechanism, and those should be definitely encouraged. I can only commend the fact that we're creating these spaces and we're collecting and bringing burn survivors together to be able to support each other in the way that we as clinicians or professionals are just incapable of doing. It's a different level up. So thank you to everyone who spoke. I've learned so much as well, and it's wonderful to hear something that I'm so passionate about being given a platform like this. So thank you, Danielle and Jenny, as well.
Thank you, Chrissy. Absolutely our pleasure. And I'm seeing comments come up in the chat as well about the information that you've all shared today being really relevant in other parts of the world that maybe haven't been represented yet in the conversation. So Len Garris is sharing that Canadian First Nation communities also have similar challenges. And so this can travel to Canada, which is exciting to see. I certainly have been wondering for quite some time about how a lot of this knowledge and these resources can be adapted into some of the humanitarian contexts where they can be quite extreme low resource and don't necessarily have the long-term support in the health systems. I don't know if anyone on the call who's still here is able to speak to this or has anyone that they think could speak to this. But certainly with our own networking leading up to this event, it was something that we were struggling with trying to identify who in the humanitarian sector and the health clusters and these different parts of the sector are really taking the lead with what burn care looks like. And so would love to hear from anyone on the call, or if you have recommendations. This certainly isn't the end of a conversation, it's the beginning of a conversation. I could see this being a topic that comes up again on the Global Shelter Cluster Fire Safety COP, because it's certainly very relevant and a challenge that isn't going away. So yeah, just throwing that out there, always looking to network so that we can continue to bring together these conversations. Thank you. Any other comments, Cheryl? I see you've brought your video back on.
Yeah, I just wanted to say, speak to this particular point, Danielle. In the fire safety work that we do, we had begun to see that an area which doesn't get the attention, like burn care, even fire safety in India, does not get the attention. And for us in fire safety, we see it all along, right? So we have started to see that alliances where there are good examples, good practices, if we are able to take that and replicate it. So we just recently did a fire drill in a school, and we call it the Fire Ready Badge, to also create ownership and pride for adopting good practices, in institutions. So we did that with a school in southern part of India, and we've connected that school, which is adopting these good practices, and started talking to another school in Bangalore, and then create an alliance of fire safe schools, for example, and then continue to build that network. So I think it would be great to see, I mean, all of our practitioners who are here on the call, and I mean, advocates of burn safety, to see how we can create this chain, and to say, okay, here's what's working. Like, for example, Chrissy, who's doing work, with communication, and with all of the information, and, that's what we need, like back here in India, for example. So how do we say, hey, here's what worked here, and how do we connect it to another good practice in another part of the world? So I think that can, because replication is a great way, I feel, when we are struggling on low resources. So just some thoughts.
Thank you so much for your reflection. I think in the short term, the immediate term, what we can do is include resources that are recommended by the panelists or anyone else on the call, and share those in the follow-up with the meeting minutes. So please do share those links in the chat or send us an email afterwards, because that's something that we can immediately circulate. But I think, Cheryl, what you're also talking about is kind of an ongoing conversation for ongoing reflections and sharing. And
Correct.
I think that is something that obviously this space is here dedicated for that, but it's not limited to burn care. It's the wider fire safety challenges. I think if there are people that are interested in having kind of a sub discussion, or there's a particular topic, then we're always happy to try to help people connect bilaterally, or if there's a request for additional meetings, we can always do that. I do want to respond to Robert Solomon's message that just came up. Really good question. What is the potential role for the Phoenix Society for Burn Survivors? Unfortunately, Amy Acton, who leads the Burn Society for Burn Survivors, was not available to join as a panelist today. She was actually in another panel at the same time, but she is someone that we've been in contact with. So as I was saying, if we do have more discussions on this, she might be someone that we want to invite. Something that I'm really inspired by with the Phoenix Society for Burn Survivors is how they really focus on supporting the rehabilitation through all those different dimensions that Dr. BJ spoke about. But also they really ultimately want to, if survivors are ready and interested, to help them become advocates for burn safety. And so it's a really, really powerful message. And how can you transform something negative into something positive? Certainly Beyond Carlton embodies this in everything that it is. So thank you, Cheryl, and your team. And so, yeah, there certainly is roles for learning from them. Another group that I mentioned in the chat with someone that we were hoping to get today, but we weren't able to connect with on this particular schedule, was the group Interburns, and they do a lot of work building capacity for burn units in low resource settings. So there is a lot of fascinating and important work happening in this space. Something that we also, I'm just speaking out loud from my own reflections, something that Kindling has spoken about for some time but hasn't necessarily found the right way to move forward is not only with burn survivors, but just people who are survivors more generally and bereaved families of fire. How can we support them connecting with each other and creating support networks, not only within their own country, but globally? We've had some really important discussions with people, bereaved families and survivors of the Grenfell Tower fire in London around this topic, and there has been some interest in these things. So certainly nothing substantial is happening, but this feels like the right group of people who might be able to make something happen in that space to really provide that kind of cross-context learning and support network. So certainly a lot of potential. And yeah, to me, I look up to the Phoenix Society in particular. So thank you, Robert, for sharing that. I think the other really, really important things coming through. So Chrissy is sharing there's resources and toolkit for National Burn Awareness Day on the 15th of October. We were very intentional about not hosting this event on the 15th of October because we wanted it to be leading up to it. So we're hoping that all of you are now burn advocates if you'd worked already before this meeting. And please look at those resources, share them with your networks. And Burns Week, World Burns Week, is the week of the 3rd to the 7th of November. So there's certainly a lot that we can take from this session to promote it through these events and networks. And of course, burn prevention and care is an all year round thing, but we need to take these moments for advocacy. Thank you. Anyone else want to jump in? We have a few more minutes.
Danielle, from my side, very quickly. So I just wanted to, well, first of all, thank you for everyone else who spoke. It was really a pleasure hearing everybody. And it occurs to me that anyone involved in something like burns, at whichever level, whether it's the clinical management or at the community level, it requires creative thinking and a very broad perspective. And I think that's often where things get stuck, because sometimes if it's a very narrow focus, the big picture is missed and the connections are missed. So what I really am appreciating here today is I get that sense of that broad perspective. And, you know, I find in general the people who would make the biggest difference in shifting something, especially things like mindsets or bringing new ideas into a community that, you know, has not been there before in a way that it actually sticks. It requires a creativity. And, you know, because it's not just fire, as we're working with fire, it is also affecting cooking on the floor and electricity supply. And then it's not just first aid, it's also first aid at the hospital. So I'm just wanting to highlight that, the necessity, and appreciate the value of that broad perspective and seeing it show up here a little bit. Yeah, thank you.
Thank you so much. And I think Chrissy maybe has an idea to follow up on your comment as well, because I don't know, it seems like it's inspiring others in the call. So Chrissy, can I ask you to respond directly, Doctor?
Yes, it just prompted me to think, Janeshri, thank you for that. And exactly, if burn care is anything, it is a creative effort, because there is no template for us for how to bandage an ear, for how to bandage under somebody's arm, or, you know, how to splint them with minimal resources. So everything had to be dreamt up by the practitioners. So we're all very much artists of our trade, but what we don't have is those examples that, even spoken today, I didn't know this good work was happening. I didn't know that these successes were there. And what would be amazing is to have like I called it a Burns Innovations Hub, but one place where we could all place our good efforts, things that have worked well, and even our failures, to say, actually, we've tried this, and with this patient demographic, it just totally didn't work. But somewhere we can all share, but one place where we put it. Otherwise, we're all working really well and doing good work, but in silos, apart from each other, whereas actually this takes all of us. It takes from home, from being very personal about it, to a whole global scale, and trying to pull each other closer together to make these outcomes happen on a global scale.
Yeah.
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 Well said.
Well, I think you have a few comrades in that already, Chrissy. You can certainly count Kindling in as wanting to support that effort, or if there's any capacity for hosting in some way. We don't necessarily have all the resources to dedicate to it, but certainly happy to help make that dream a reality. So I will say, if anyone on the call is interested in that, I shouldn't volunteer you, Chrissy, but I'm guessing that you'd be open to having a conversation with them about shaping your idea. Yeah, I'm just knowing you, Chrissy, knowing you're quite like keen normally. Okay. So yeah, please. And if you're comfortable, Chrissy, maybe you could put your email in the chat so that people who are interested can connect directly with you, and hopefully the panelists will also be keen. Please, anyone else who wants to connect with Chrissy, feel free to put your email in the chat. Really trying to respect the data privacy, so it's your choice to share that. Otherwise, we'll check in with you if someone wants to connect with you. With that, I think this is a really great note to end the call on. Thank you so much. We've had over half the group stay on for the extra half hour, despite our scheduling error or miscalculation of how long this would take, because it was such a fascinating and interesting conversation. I'm also really happy that this is all recorded, because I do think there's a lot that we can share beyond this meeting. Again, we'll be in touch with all the panelists separately to get permissions, but hopefully in at least some form of this recording with whoever's comfortable will be shared, so you can share it in the Burns Week. Look at those resources. We'll share everything we learned today. And finally, with that, I just want to say thank you so much to all of our panelists. I've learned an incredible amount today, and I know everyone else has, even the panelists from each other, it sounds like. So thank you again, and we will be in touch soon with our next meeting. We're going to be looking to get one more in before the end of the year. There are several topics that we're working on, so we'll see which one makes the win for the last of the year. And otherwise, we'll be in touch over email and on social media. And I hope you all have a great rest of your day, whether that's morning, afternoon, or evening, depending on where you are in the world. So thank you.